And the panel that we're doing right now is going to be managing population health amid financial uncertainty. I think everyone knows that. Like, finances today are really tight, and when finances get tight, what gets cut? Budgets and resources, and per some of the conversation in the prior panel, at times people look at some of the pop health programs, and so that's certainly one where, from I think everyone on here believes that there's huge opportunity, so there's good opportunities for us to share with you strategies and things that we're doing. Sound like a plan?
Yes.
Excellent. I like it. So immediately to my left, your right, is going to be Nate from Curana. And Nate, in addition to what he's doing at Curana, he's a bean expert, heirloom bean. Yes, so you can talk to fun facts. Well, so what's the purpose of the fun facts? We're going to be together for a couple days now, and obviously Curana, by the way, they're our #2 volume user of EndNote. So you could talk to Nate about some of the phenomenal results that they're getting. But in addition to that, you know, it's always interesting when you're able to connect with someone on a personal level. So you could talk to him about beans. Next to Nate is Phyllis. Phyllis is with Real Time Medical Systems. And so if you want to talk to Phyllis, that you could talk to her about beaches and island life. She was recently at Hawaii. Who likes Hawaii? Everyone. So there you go. Next to her is Amy. Amy's with Impact Primary Care. So they're in North Carolina. They were created when Mission did the for-profit, non-for-profit piece. Then the non-for-profit to for-profit. There was a org that was created that funded their organization. And so she's in that zone of rural healthcare, really trying to bring providers together. And as someone who lives in that area, she loves the outdoors. And so she could share with you hiking and other things around there. And next to her is Emily. Emily's with NAACOS. And Emily, fun fact, has a son who lives in the area here who does fabrication. And so you'll see at the Super Bowl some of his work. Ooh. So now you've got a sense of the panels, great diversity as well from a range of different, care delivery models. So it really highlights how pop health can impact everyone. So Emily, since you represent NAACOS, so you're looking all around, maybe just this is the chance for everyone to share a little bit about your overall perspective on managing populations with financial uncertainty.
Yeah, thanks. Thanks, Brian, and hi to our members who are in the room. If I haven't met you yet, please say hello. So before we jump in, I don't want to whistle by the financial uncertainty piece. It is, a time of serious financial uncertainty, volatility. If you're looking at loss of coverage for Medicaid or ACA plans, and the inverse of that, more on and underinsured people who seek and receive care from providers. And then all of the other ways that I think providers are amazing at cross-subsidy. So all the other kinds of funding mechanisms that close the gap on fee-for-service, those going away as well. So significant financial uncertainty. And I think many people, many providers saw and still see this work that we call population health, accountable care, total cost of care management as a hedge against fee-for-service. And we certainly saw the benefit of that, many of us, during COVID, particularly those that were paid prospectively. And then the inverse, right, under the increasing fee-for-service, where the fee-for-service is going up and pop health dividends are going down. So it is, in fact, we see that, it is that hedge. And so the temptation, I think, at times of financial uncertainty, as Brian alluded to, is to kind of go with what you know. And so what I hear from most of our members is they are back in those conversations around the why. Why do we do this work? Why is it better for people? Why is it better for our communities? So they are not the focus of cuts and in resources and people. So really digging into that, and I think we'll talk a little bit about the ways that we're doing that today.
Awesome. Amy, do you want to go next?
Sure. Hello, everyone. Amy Russell. I'm first and foremost a family doc, and I still practice full spectrum family medicine. So that means still do prenatal care, pediatrics, adult, seniors. And my background, I've been practicing for almost 30 years. I started and have always worked in rural underserved community health backgrounds. I started at Clinica Campesina in Colorado. And I was fortunate as a resident, I got to participate in the first Health Disparities Collaborative with the IHI. And so I've been thinking from a population health perspective since my very first years in family medicine. We made our first registry from an Access database back in 1999, but it helped. We tracked our outcomes and improved our outcomes and understood that a lot of people we thought were non-compliant really just couldn't get in, and we had to manage patient populations better. I went through the whole transformation of team-based care in family medicine, primary care medical home, and returned back home to North Carolina. I was a rural health scholar in North Carolina, and returned back home to work for Mountain Area Health Education Center as we were transitioning as a community into value-based care. So MAHEC is a workforce development organization. We're an AHEC. We are the School of Medicine for UNC for the Western Campus. We have 35 students a year. We have 200 and some residents, so we have several residencies and several fellowships. And our goal is to create the workforce for rural Western North Carolina. So what we're trying to do is train very competent primary care providers who can go to rural communities and can be supported and feel successful there. So we've been looking at how to care for the 18 counties of Western North Carolina for a long time. So that is a population health perspective, and that has a workforce component. It has a population component. And many of the graduates in Western North Carolina come from MAHEC, so we all kind of know each other, and which is a great way to get people to collaborate. So we've been engaged in a variety of different value-based arrangements throughout the years. MAHEC has, there are very few payers that were not in some kind of value-based arrangement. It is very fragmented. So I also represent, which is not uncommon for rural areas, that leaders have more than one hat. I'm also the Chief Medical Officer for Impact Primary Care Network, which was developed out of the North Carolina Healthy Opportunities Pilot to create infrastructure to integrate social care and health care. So Impact Health is a network of community-based organizations, and we were the first in the country, actually Western North Carolina was the first in the country to have a payer pay for a social need. And that was a food box delivered to a family. And we implemented a network of transportation, housing support systems, food insecurity, and support with individuals who are experiencing stress and interpersonal violence. And so that network is now integrated with Impact Primary Care Network, which is a network of independent primary care practices in Western North Carolina. We are new to Innovacor. We've been in Innovacor for a year, and we really transitioned for the care management component and the population management component. And a lot of our practices were participants in making care primary. We chose that pathway because of the alignment with North Carolina Medicaid and the ability to expand our care management model, and then it ended. And so we've quickly had to pivot to the billing advanced primary care management. So all I can say, and I'm talking too long, I'm sorry, is that there's never been a time we haven't been completely financially stressed. And we had Helene, we had COVID, and now we have measles. So it's just nonstop. So I love to talk to you about what we've done to overcome those stressors.
I got my hand, thank you. That was a great story, and I'm a nurse. My name's Phyllis Wojtusik. I work with Real Time, but I'm going to go back and tell you a very shorter, similar story, though. I worked in critical care much of my career for Penn Medicine, and I did cardiac care. That was my love, CHF. Well, most of the CHFers you take care of are older adults, and that led me to geriatrics. And I opened a geriatric practice, and we had a fellowship, and I just had such a passion for those people because they are underserved. If you see them, sorry, I don't mean this in a bad way, in a normal primary care office, they're not always equipped to deal with all the comorbid conditions, all the social determinants, all the things that that population faces on a daily basis. And so with that geriatric practice, that led us to nursing home work because you couldn't just survive on office practice with 30-minute visits because we got hounded financially all the time. You need to get more visits in, so we did nursing home work. And the number of patients that I saw who could have been helped prior to being admitted or readmitted to the hospital was crazy. If only someone looked at the data. They could have prevented it. It would have been easy. An extra dose of Lasix, a wait once a week. Very simple things that weren't being done. And so it really became my passion to get data and expose the data, if you will, in ways that impacted patients' lives on a daily basis. Because the financial stresses that we all share and we all have, if you just focus on that, you lose your mission. Look at those people one at a time, focus on their outcomes, focus on what you can do, and that's what will help you kind of move them through the continuum or get them to where they need to be. So I'm very passionate about geriatrics, senior health, and CHF still. But I think that data that's not used is just, data. But if you start to really look at that data, pull it up from the patient level to the facility level to the ACO level to the population health level, it will show you the way to go. Thank you.
Amazing. And rounding us out here, Nate.
Great. So I work at a company called Curana Health, which I want to tell you a little bit about, set some context for, I think, why I'm up here today. But kind of in the same vein of what Phyllis is talking about, we focus on seniors in congregate settings. So Curana is a value-based care company. It's been in existence for about 5 years. And we do a couple things. We have a health plan that is a Medicare Advantage plan, mostly doing institutional special needs plans. So again, touching on these senior congregate care settings. We have a medical group that is SNFists and people that practice in assisted living, independent living. And we have a couple ACOs. So we are proud members of NAACOS, having both an MSSP and a high needs ACO reach. And we're doing a lot of these different things together, all in the pursuit of improving the health, happiness, and dignity of these senior living patients that we get the opportunity to care for. And in those settings, very complicated patients, I think as Phyllis alluded to, a lot of needs, a lot of really unfortunate circumstances that got them there. But once they've gotten there, what I've found in my healthcare journey is that a lot of time people didn't have a great experience in those SNF long-term care settings, right? They weren't really getting longitudinal care, and they generally weren't getting population health kind of focus. It was more focused on acute problem management, right? How do we treat what's in front of us and move along? Well, these people live there, and as we grow older as a country, more and more people are going to live in these settings, and so we need to think about the paradigm of care in assisted living, more so in nursing facilities, a little differently. We want to start extending the same things we do that a lot of you probably do in your office-based primary care practices. We need to do those things as well in these senior congregate settings, and that's what Curana is really about. We've been a Curana client, an Innovaccer client for a few years now, and we use a couple things that I think are really helping us in this journey. We use InNote very extensively. As Dr. Silverstein said, we have a lot of users on that platform. They use it very regularly. We also use InCare, thinking about a lot of the care management tools, supporting care, complex care management or APCM or TCM, and we're looking to continue to grow. So did you want me to comment on the question, or are you going to tee that up in a minute here?
I'll tee it up, and then you could comment on it while you're still there. And so one thing, I love that we have such a diversity of panelists. So you've got, a very interesting model. You got post-acute care, real-time rural primary care, which is the reality a lot of people face, and we have the most prestigious national organization for value care delivery, the leader of joining us. So we really do have a star cast here. One of the things I'd like us to dive into is that a lot of the people in the room, we're all facing a lot of these same challenges and issues, and so let's share some words of wisdom. Give me an example of something that you're doing that has produced a clinical or financial result. That you're like, okay, here's, what's the nugget or idea of something you could do, share that we've done this, we have a result, and so here's an idea for you. And you want to start with that?
Yeah, sure. So I think one thing, the way we use InNote very specifically, we have providers that historically have had a very fee-for-service focused mindset. They do something, they get reimbursed for that. So one of the ways we've used InNote, which I'm told is somewhat unique, is we just very simply say, we're going to give you information about conditions your patients may have, and we want you to assess them. You tell us, do they have it or not? If they have it, well, good, let's treat it and make sure that it doesn't cause a complication. And when they assess those conditions, we give them a bonus for that. We straight give them a bonus for assessing, not for documenting, because that, of course, is not what we want. We want them to determine if a condition is present or not. And giving them that bonus has led to a really dramatic increase in the number of conditions we assess, and I would say the accuracy of our documentation. That, as you all are probably very well familiar, leads directly to financial impact. Certainly in high needs ACO REACH, where if any of you aren't aware, there is a concurrent risk adjustment model.